Okay, there we go. All right, Taylor, take a second, introduce yourself. Thank you for being here. I appreciate it.
Of course. Thanks for having me. So I'm Taylor Nichols. I'm an emergency medicine and addiction medicine physician in Northern California. And let's see, I've been in practice now for 6 years out of residency. Um, and I did my residency at UCSF here in San Francisco. You'll see behind me.
Yeah,
Um,
excellent
and
achievement.
uh,
Yeah.
and went to medical school at UC Davis. So I'm a Northern California lifer.
Swimming today.
Yeah, yeah, right. Yes, it is
Yeah.
indeed.
Okay, so this I think is a really important lesson for all of us to take. Like when we go to the ER, we need to have expectations that are realistic. So,
Yeah,
what is the purview of the ER? What should we expect when we go in?
that's a great question. So the goal of emergency medicine and what we are trained in is to treat acute intermittent care, acute intermittent needs. Um, we are experts in resuscitation. So if you are super sick and you come into the emergency department, we're the people that you want to see. We're experts in trauma and trauma resuscitation. So if you are in suffer a traumatic injury, you will be taken to likely a trauma center if you have one nearby. And the people who work there are emergency medicine physicians who will specialize in, trauma care. And often if it's a large center, you'll have a trauma surgeon as well. But those are sort of, acute medical resuscitations and acute trauma resuscitations are sort of our like specialty. And then the rest can be anything. I mean, any acute intermittent care needs. Um, Obviously, we see much more than just emergency situations. And
Right.
so it's a little bit of a logical fallacy to think that like an emergency department is only for emergencies. Like patients who come in aren't physicians who have diagnosed themselves with an emergency condition. The point is to diagnose potential emergencies and make sure that those are cared for.
Yeah, and let's explain the process of triage. What is
Sure.
triage, and what does that mean?
The triage can vary from hospital to hospital in terms of how they do it, but the concept is the same. You are evaluating the severity of a patient's presentation of their illness, and then assigning that sort of a scale from 1 to 5 in terms of how severe it is. And something like a stroke, a heart attack, anything that's like obvious is a level 1. Like if you present and you're super sick, that's a level 1. Something that would be like a level 2 would be things that are potential severe emergencies. So if you have something that, say, isn't obviously a stroke, but is a significant neurologic complaint, things like chest pain that sounds sort of cardiac in nature, severe shortness of breath, where you're actually like working hard to breathe.
Oh, that's
Those
serious.
sorts of things can be like a level 2. Things like a level 3 is sort of like a gray area, but things that are not emergencies that need to be seen immediately, but could be threatening. So often things that are like abdominal pain will often be a level 3, because say you have appendicitis, that is a severe medical issue, something that we need to address quickly, but is not like an immediate life threat at that moment. Then things level 4 is like if you maybe rolled your ankle playing basketball and it's a sprain versus a fracture, something that like you need an x-ray, needs to be evaluated, needs to be treated, but is not a threat to life or limb. And then a level 5 would be like a medication refill, like baby comes in with like a diaper rash, those sorts of things that need to be seen, and people need care, but that's not an emergency. You're not going to bump somebody in line for that thing.
I know you're having a heart attack, but I got this thing.
Right, yeah.
I,
Yeah, you're not gonna bump the guy with a potential heart attack for the like diaper rash
yeah, I,
or the sprained ankle.
yeah, yeah. It's gonna be okay. They'll get to you, but we
Right,
gotta get Bob over here because he's
right,
coding.
right. Yeah, exactly.
So when and why should we go to the ER? I know that's a nebulous question, and we've talked about this with heart attacks before. It's
That is
tricky.
so hard. And if we lived in a perfect system, the answer would be different, right? If we lived in a perfect system, it would be only for an acute intermittent need that truly you couldn't like wait until the morning to go see your primary care doctor. That would be the ideal situation, but we don't exist in a perfect system. The
Sure.
system, as we all know, is completely broken, and accessing care is incredibly difficult.
Yeah.
So I would never tell anyone not to go to the emergency department, because if that is the place that you can access care, we are there, and we picked this job to be there 24/7, 365. Our motto in emergency medicine is anyone, anything, anytime. We will see you, treat you, see you, evaluate you, and treat you for anything. I like to call it the door threshold. If you cross the door threshold, you need to be there. The reason you cross that door threshold is not for me to determine. It's because you needed to access care, and this was the place that you knew you could access it. Now, maybe you have a primary care doctor and they're great, but they have like a 6-month wait, and you have a need that can't wait 6 months. Then, you can come to the emergency department. Can you go to an urgent care? Sure, but also urgent cares aren't open 24/7. We're the only place that is open providing care 24/7. So I recognize that. And I as somebody who like worked only night shifts for 5 years,
Yeah.
I saw all of it, right?
Oh,
Because there aren't any urgent cares open at night. And so I really had no concern about what your reason for being there was. I think if in the system that we exist in, if you are able to access care in a different place, it is not urgent enough to need to go to the emergency department, then from purely a financial perspective, it is cheaper to access care in other places, and the reason isn't just because of like physician fees. It really, I can bill the same as an urgent care could from a physician fee perspective for the same complaint, right? We bill based on the severity and acuity of illness and the amount of work we have to put into evaluating and treating it. And if my evaluation and treatment is the same as your primary care doctor and urgent care, we're billing the same amount. The difference comes from what we call facility fees.
Yep.
And I think this is the hard part about health policy and the cost of care that is hard for people to understand. And it's difficult because it is so opaque and so nebulous, and the numbers are picked out of thin air, it seems. But what facilities are is that facility fees are essentially that we staff an emergency department 24/7. We have to pay for the equipment for that, the nurses for that. They have to pay for the hospital, right? And so it's
Liability.
all the fees that are tied in to that. And this is also why, frankly, you're seeing freestanding emergency departments pop up in a lot of places that could be urgent cares, but and the theory was, oh, well, we should allow freestanding emergency departments to treat, like rural communities that don't really have these big hospital systems. And then they will have contracts with the big hospital system. So it's easy to just transfer patients. The reality is that they're popping up in well-insured areas with wealthy patients because they can bill the facility fee and say, we have to pay for, nurses, techs, CT scanner, all those things. And so we're going to bill at a higher rate, even for those low acuity scenarios, right? Just so that you can be prepared for those severe situations that truly need an emergency resuscitation. So that is the reason, in my mind, to not go to an emergency department from a financial perspective if you are able to access appropriate care in another location. If that is the only place you can go, that is the place that you should go, because everyone deserves to be able to access care.
Yeah.
I know that's like not a perfect answer, but
Oh,
it's unfortunately the reality of the capitalistic system that we exist in.
yeah. I don't know if I've told you, my dad is a hospital administrator. He started out as a pharmacist and EMT in the Navy during
Really?
Vietnam. You know,
Oh, good for
Navy, they
him.
break a bottle over your head, conscription. So at 15, I was doing coding, billing, transcription, all that stuff.
Gosh.
It is way different now than it
Yeah,
was in
that's how
1985.
you took this medical route. I see.
Yes,
I get it.
it was not by choice. Well, maybe some of it was because it was good pay at the time.
Yeah,
But
right.
yeah, it's and we've had similar pop-up ERs in Kansas City, but they just haven't really
Yeah,
stuck. So
right. Oh,
and
interesting.
and it's
Okay.
exactly like you were saying. They tend to be in more affluent areas.
Hmm.
So
Yep. This has been, they've existed for over a decade now, and there's now, plenty of data to show that the thing that they claimed that they were going to be able to do, they just haven't done.
yeah, yeah, and the system right now is so overburdened. It was overburdened before COVID, but now it's like,
Yeah,
wow, RIP.
that's
Thank you.
that's a that's such an interesting point. Um, and I think there's some complexity there that's worth exploring,
Yeah.
if you don't mind taking the
Oh,
time.
no, go for it.
Um, so what happened during COVID to the medical community was we were being asked to essentially risk our lives to do more with less.
48 hours a
And
day.
then we saw, yeah, and then we saw society stop caring entirely about us, especially with this propagation of anti-vaccine campaigns and anti-mask campaigns, and all of these people not caring about each other, about the idea of like just simply denying that like COVID
Public,
existed
yeah,
as a virus
public
and
health.
that people were dying. And
Yeah.
the emergency department I worked in at one point, we had to like have extra security because we got threats of people wanting to come expose us for not having any patients, and that it was just so wild to be in the middle of a scenario where you're like, yes, our numbers went down because nobody wanted to come to the emergency department
Yeah.
because nobody wanted to get sick, right?
Yeah. That was me.
And that's where the sick,
I was not going in
right?
there for
That's
anything.
where the sick people were coming.
Yeah.
But our numbers went down.
Uh-huh.
And because our numbers went down and we exist in a capitalistic system, people got fired, like physicians, nurses, they cut a bunch of staff. And then we weren't prepared for the ensuing, waves and surges that we got. And so then we went from being fully staffed to having a big drop in patients for the first like 6 months and cutting staffing, and then being massively overwhelmed without enough staffing. We would have been overwhelmed even if we did have enough staffing. And then we went into crisis mode to get more staffing.
Yeah.
And then a bunch of people who experienced all of that, experienced society not caring, experienced the hospitals and insurance system, all of that not caring and firing people, and then struggling to get staff, decided if you don't care about us and you don't want to value us for what we're doing, we're just gonna leave.
Yeah.
And a lot of people left, and we don't have the ability to just ramp up our staffing rapidly, right? It takes a long time to produce physicians, nurses,
Yeah.
respiratory therapists, all the people who left.
Yeah. You don't go on Craigslist and be like,
We
hey.
already were facing a shortage across the board of enough providers, because we know that as this older generation is aging, they're going to need more care. There are more people in that cohort that are going to need to access more care. And then on top of that, people got really sick. And so we're in the emergency departments watching patients suffer and die. and then people are trying to break in to tell us that it's not happening and it's all a farce. And the like dichotomy of the two worlds that we had to exist in and the social isolation was, it broke a lot of people. It made it hard to continue doing that when it's like, I don't know why I'm here. And then that becomes compounded, and it becomes a struggle now because the system has fewer people trying to do more with less and is overburdened. And on top of that, with COVID, with the public health emergency, essentially everyone got access to an insurance, to like at least Medicaid, right? That was hugely important.
Yes.
What I think people don't realize is that the amount of staffing went down, the amount of patients went up, and this is our first attempted experiment with universal coverage. It doesn't mean universal care, and I've been beating my head against the wall since the first discussions about the Affordable Care Act. It was not a healthcare bill. It was a health insurance bill, which allowed for people to get insurance, and that's fantastic, but it did nothing for the actual care they're able to access.
Exactly.
Right? And so expanding insurance access is hugely important, but what we needed to do was have a discussion about how we were going to provide care to all of those people. And we didn't. And then we finally got to the point where we said, okay, this is a public health emergency. Everyone can access Medicaid. Great. And so we had more patients, and those Medicaid patients, by the way, Medicaid pays cents on the Medicare dollar. Medicare pays cents on the private insurance dollar. So you're talking about Medicaid paying like pennies compared to private insurance. So who's going to take Medicaid if they are voluntarily taking insurance? Primary care doctors, et cetera, unless they're with a big hospital system
They can't afford
that takes Medicaid because they need to for their patient population, et cetera. Like private clinics don't, subspecialists don't have to take Medicaid. And so that is why the wait list to get in to see physicians for all these patients who now are on Medicaid was so long. And so where did they go? They turned to the place where they could access care, which is the emergency department. So then what happens? The emergency departments are overwhelmed, trying to provide access to care for everybody, but also providing emergency access, like for true emergencies, and do what we did before. And what we did before, by the way, like pre-pandemic, was already bad and difficult, right? Like people still didn't have good access to care, but now it's even more limited. Now there's fewer physicians and more Medicaid patients. So we are failing at our first experiment in universal coverage, not because the idea is bad and not because I want people to not have insurance, but because we need to have a better way for those people who are now insured to access care. Canada, interestingly, what's that?
I've worked in offices even years back. They stopped taking Blue Cross Blue Shield because it's the same thing.
Right.
They can say that. They can do that.
Right. And so what I think is interesting when people have these discussions about what universal coverage and universal care looks like, Canada is often the example that's brought up, and it's not a socialized system. There are still private, independent organizations, hospitals, et cetera. They are their own for or nonprofit groups. They accept the insurance that is provided by the government, right? It's funded by the government. That's the distinction, is it's not so the government doesn't own all the hospitals. It doesn't pay all the salaries of the physicians. Those are their own organizations that decide how those run. What is happening in Canada, because it is a closed system, because they only have one insurer, which is the government, is they've realized that they are also facing a crisis, the same crisis that we're facing. Staffing shortages, inability to access care, not enough primary care physicians, and realizing that they have mismanaged this for decades because primary care is underfunded, because we pay for the things that we perceive as valuable, like orthopedic surgery, that they make a ton of money. Primary care doctors don't, because we value procedures more than maintaining, people's health
Yeah,
at just baseline,
so backwards.
right?
Like
Like
prevention
that's,
is always cheaper.
yeah, it would be better if we funded that. So what Canada is doing now is recognizing that they failed miserably. They are rapidly increasing the amount of reimbursement that, say, primary care physicians will get for the care that they can provide, because to try and incentivize, and they're reducing barriers to try and allow people to, like, say, from the United States, who are board certified here, to go work in Canada because they have such a need. I have a friend who actually is Canadian but did all of her training in emergency medicine in the United
Oh,
States,
wow.
and one of the barriers is that they do 5 years of emergency medicine residency there, and we only did 4, and so she would have had to do an additional year of training if she wanted to move to Canada, so she never moved to Canada. What they've done now is they've eliminated that barrier
Oh, that's cool.
because there's such a shortage, and so now she's going to Canada, and so she can work there. So when you have a system that is closed like that, and where the rich people are being impacted the same way poor people are impacted in a purely capitalistic system like ours, people actually start caring. The problem is that it's only the poor people, only the people on Medicaid, only in the underserved communities where people are being truly, truly harmed by the way the system is set up here, and where they can't access care. And so when it's only marginalized communities already, nobody does anything about it, unfortunately.
Yeah, my first 2
Um,
rounds of COVID, I did not have insurance. And on June 23rd, 3 days before I started this group, I was getting out of the shower and I had this pain, and like this knotting pain in my chest on the left, radiating down my arm. I didn't, I was, shoot, I just called a friend. Doors unlocked, just come in if I'm on the floor, take me in. Call an ambulance.
yeah,
We should
right.
not be at that point.
No, I mean, that should be a situation where you immediately, you recognize it, obviously,
Yep.
where you go to the emergency department,
Oh, God,
right? That is a heart attack until proven otherwise. And you are the person, like I said in the triage sheet, you would be a level 2, right? You're describing a heart attack, not necessarily a level 1, unless you had signs of it on like a screening EKG that they did in triage. But again, that's incredibly concerning. We should exist in a system where that is reasonable and accessible to you, and unfortunately we don't.
Yeah, I made a post on Facebook like, I don't know what's going on, guys. Just never stop telling my son how much I love him, and
I am so sorry that happened to you. That's terrible.
I've grown up in this system. I know the
Right,
system.
right.
It,
you
it's
you know better,
yeah,
well enough
yeah,
to know how bad it is.
yeah. It's scary.
Yeah, I'm sorry.
Well, I was able to get on insurance. I got on Medicaid just in time for my first ER visit after I got it the second time with tachycardia and all that stuff. Got to take my shiny new Medicaid out for a spin.
Yeah.
I was like, yay, I can go now.
Oh man,
Oh, the world
yeah, sad statement.
messed up.
Yeah,
So what scans or like when we're talking about EKGs and other scans and labs,
sure.
what should we expect? What should we not expect?
Um, so what is sort of within our ability, what's within our scope, is essentially we can do sort of anything that will come back immediately within the time of that visit. So your more basic labs, looking at liver function tests, complete blood count, chemistry panel, urinalyses, chest x-rays, CT scans, all of those are sort of common. It will obviously depend on the complaint. If it's related to your abdomen, then there are a lot more labs that will check. You're more likely to get a CT scan. If it's a complaint related to your chest, often labs and a chest x-ray, EKG. And then obviously like extremities often will end up with an x-ray. MRIs are not always within our ability or scope, and it depends on the severity of your condition. If there is a potential emergency that needs to be ruled out, that can only be evaluated by an MRI. If you are in a center with MRI capabilities, some facilities will have MRI capabilities from the emergency department,
Not every
but it's often a really long delay to get to an MRI, and MRIs take a long time and all that. So we may either admit you to the hospital just to be able to get that study, or we'll put you, if the system has this set up, like a clinical decision unit where you are waiting for a test like an MRI. And then when that's done, we decide whether it is an emergency condition, you need to get admitted, or it's not, and then you get discharged. So that is the difficulty. In some places where they don't even have an MRI machine, if it is a true emergency that needs to be ruled out by an MRI, you might get transferred to have access to a MRI capable facility. But yeah, generally within like the X-ray, CT scan, maybe ultrasound, and basic blood work that will come back rapidly.
Yeah, and things like troponin, stuff like
Yeah,
that.
a troponin test, which is a protein that's produced by your heart, is a sign of a heart attack. That will be something that comes back right away. Like a lipid panel won't come back right away. We don't order that from the emergency department.
Yeah.
Some things don't come back right away, but we'll still send because it is an important part of your care, especially if you're going to get admitted. And so that'll be followed up by the doctor who admits you to the hospital. But things like some like endocrine related tests, if you need to be admitted and it might take days, if you're going to be admitted to the hospital and you might be there for days, and we might send that, but it's not a test that we will be able to send out, get the information back, and then like call you to follow up. Because, for example, you don't want me to do that where I'm only in the emergency department, like anywhere from one to twice a week on average. And so if I send a test and I get a bunch of tests back a week later, if it's important, like it's probably better that you get that tested in a different setting.
Well, and that's what we have these specialists for. Like an endocrinologist isn't going to be
Right.
like, let me take a look at your white blood cells. No.
Especially, yeah, right. Especially because I might get a result that I don't know what to do with. If I'm sending an endocrine related test, that's not my scope, and I'm not the person to see that test. And if you don't have an endocrinologist to follow up on it, then what am I like? What can I do? Nothing. I don't have the ability to then subsequently call up some random endocrinologist and be like, I have this patient that you don't know who had this one test, and I don't know what to like. I can't get you into that clinic just by like calling with an abnormal result. So that's one of the hard parts, is that we aren't specialists in all the things. We are specialists in emergency care, which, like I said, not everybody who comes in has an emergency need. That's okay. We just need to understand what our actual scope and capabilities are.
Let's and what when we go into the ER, what kinds of things should we bring in with us? Like besides wearing a good face mask, still, please.
Sure. Yes. Good point. So if you suspect that you might be there for a while, well, let me couch that. Any emergency department visit has the potential to be a very long wait, right? Depends on where you are and what the scenario is and what you're going in for. Just in terms of the waiting room, bring a good book, bring your phone, and bring a charger. Absolutely, that sort of as a bare minimum. If you are coming in for something that might require a long admission, come at least prepared that you are going to stay a while. You need your charger, you need your phone, you need to have contact information. That's another important thing. Bring contact information to somebody who can make medical decisions for you if needed, who can be a contact to pick you up,
Yeah.
that sort of
If you
thing.
keel over or something, if you can't
Right.
talk, yeah.
Yeah, we need to be able to have that information. Bring in a list of medications. That's super helpful.
Yes.
Bring a list of like your medical conditions, your medications, anything, any allergies, and then anything that you specifically like want for your care in general. If you're like, I don't want to be resuscitated if my heart stops, like we want to know that up front. Even if you're like coming in for an ankle sprain, like that's okay.
Yeah.
We'll put it in your chart so we know.
Yeah.
Because that we want to respect people's wishes, and we can't if we don't know what they are.
Exactly.
So if you have just, even if it's something that you can like put in your wallet, just a list of your medical problems, a list of your medications, your allergies, and any medical needs, wants, desires for your medical care in general, include that.
I actually, this is kind of a sad statement on things, but I actually have 2 extra long chargers. So wherever I am, and I'll bring a couple of battery packs with me because you don't
Yep.
know.
Yeah, if you have a battery pack, that's a good one too. But yes, having a phone is super helpful. I mean, not just like to entertain you while you're waiting, but to be able to contact folks if needed.
Yeah, and do have someone designated in your contacts.
Yes, yes. Thank you for saying that. Yeah, if you put it in your contacts, like make sure we know. And if you can, on that same piece of paper where you put all your medical conditions, put your emergency contact
Hi,
so we
Donna.
know.
Thanks for being mine.
Yeah, especially because and if you can carry that on your person at all times, because we do, like
You never know.
obviously it sounds a little bit morbid, but like we have people who come in and they get hit by a car or something and they can't talk to us, and we're like, we just look through your wallet or try and unlock your phone so we can see like who can we call, who's your contact person that we can call to figure out anything about you or who you are or what other, what we need to know in terms of your care. So it's useful to be able to have something like that with you at all times. And I would definitely bring it to any medically related visits, particularly in the emergency department, where we might not have that just like saved in your record already.
Yeah, you don't know these things already? Oh my gosh.
Right. Yeah, the number of there are a lot of times, so I think it's important that people understand that like just because an electronic medical record exists, if it is not within the same system, so many places have different electronic medical records. And
Yeah.
even if you're on the same one, like there's Epic and Cerner and Meditech, even if you're on the same one, they don't always necessarily talk to each other. I don't automatically have all of your visits information from a different hospital system, even if they're on the same system. We have to request that information. Now, it is easier to request that information from, say, I'm on Epic and they have Epic, I can request the information and I can get it more immediately. But if it's not, we need to actually send a fax to the other hospital to request your paper records.
Fun.
Yes.
Just don't code yet. Hold on. Let me send it.
Yeah. Right.
What kind
Please wait for this fax to come.
Hold on, Bob.
Yeah.
Decompressions. And what kinds of questions should we be asking?
Oh, that's
a lot, right?
That's a lot.
Very nebulous.
So I think everybody should be aware of what kind of care they are receiving and what is happening to their body. So if tests need to be done, understand what tests and what they're for. If imaging or scans are being done, understand what those are being for and being obtained for, any risks and benefits, if those are of concern to you. Feel comfortable asking those questions. Yeah. I don't always readily explain like, oh, we have to, I'll say, oh, we need to do the CT scan because we're looking for appendicitis. Not everybody shares the same concerns, and I don't necessarily need to have the 5 to 10 minute conversation about all the risks and benefits of doing CT scans. But if you do, I will gladly have that conversation with you.
Yeah.
So I have had people bring that up to me, and I can, sit down and explain it. I have an app on my phone that shows like the relative radiation risk of
Oh, cool.
all the like CT scans that we do. So I'll pull that up. But I think understanding what is being done, if like physical exams need to be performed, like doing a pelvic exam, any sort of invasive exams, then it's important to understand why those are being done. I definitely try to inform patients of what I'm going to do. I walk them through things that are more sensitive as I'm doing them to explain, but not everyone may necessarily do that, and it is within your right to ask.
Yeah.
And you should ask and know what is being done and why. Sometimes I have a hard time when patients are like, oh yeah, I went to the doctor, they did all these things, everything was fine. I'm like, I don't know what any of that was though. Like,
It was
there's like,
12
I
what?
can't, and I can't see it in the medical record because
Yeah.
you went to a different hospital system. And so it's really hard for, it's really hard for me sometimes if patients don't know what is going on with them either, because the physicians didn't explain and they didn't feel empowered to ask about it. And I want patients to feel empowered to ask those questions, because it's important to understand what is going on with your body.
Yeah.
If you're diagnosed with something, ask about it. If they say, oh, you just have this, some things we assume are more obvious, like, oh, you're having a heart attack. Most people understand that concept,
Oh,
but
yeah.
like, that's actually not intuitively obvious what is actually happening. Like, you have a blood clot that is in the artery that goes to your heart that is causing heart muscle cells to die. Like, we can have that conversation and what the consequences would be if we didn't treat it.
Yeah.
Same thing with things like appendicitis. People know generally what appendicitis is, but like, you have an inflammation or potential infection of your appendix, and we need to give you antibiotics and then cut it out, like have surgery to remove your appendix. And what does that look like? And what is the surgery like? Like, you should feel empowered to ask those questions. Obviously, I might not be the best person to answer surgical questions because I'm not a surgeon.
It's much
And I will tell you that if you say, hey, what kind of surgery is this? I'll be like, look, this is generally what they do. I'll call the surgeon, and you're welcome to ask them when they come down to talk to you about what the surgery is going to be and how long it is, and what the recovery time is and all that, because that's not my specialty. But I can point you to the right person to have that conversation, right?
I understand. I get that. I don't know what I'm doing, but I know who does.
Right, exactly. And that's a huge part of our job. It's why, sometimes people give us a little bit of a hard time because we call them and we give them work. It's like, hey, this is outside of my scope. I need
Right.
you to do this.
This is what you did that extra few years for, so come here.
Right. Yeah. So this is your specialty. Please help take care of this patient.
Yeah. And what kinds of things should we avoid doing, or like, because we want to be mindful of the people who are servicing us in these
Right.
situations. It's a hellscape right now.
So I think that's
Yeah, that's a loaded question.
I think it's a hard balance. Like, we want to be understanding of where everybody is. We want to like meet patients where they are. But we can only operate within like the scope of our capabilities and our knowledge. And we, while I said certainly we can like call the people who have better information, whose specialty it is. What in terms of expectations, like, we are calling those people when there is an like acute or emergency medical need for that thing.
Yeah.
So if you're like, oh, I have this, orthopedic surgery scheduled for 6 months out and it's really hurting and I don't want to wait, I can't just like call the orthopedic surgeon and say, hey, this patient's here, they're on your list for an operation like in 6 months, and they just really want their surgery now. Like, that is not
Yeah.
something that I can't make them take you to the operating room. I also can't make the hospital,
job, but
right? Like, I can't make the hospital have the OR time available to do that, right? Like
Yeah,
there
staffing limited.
are many different factors at play in your care, and everyone wants to be providing the best care possible. We're not here to be an impediment to your care. We're doing the best that we can within the system that exists as it exists now, and within our scope. And one of the hard things within emergency medicine is that we see a lot of things that are um, not acute intermittent needs or not emergency needs. And we want to be able to help you, but we can't always be as helpful as patients want us to be.
Yeah.
We can't always find answers. We can't always send the test that you think you need or that you do need, that you like, say you have had like a telehealth consult with an endocrinologist and they're like, oh yeah, you need to do XYZ test and you need to go to the lab and blah, blah. Like we aren't just like the overnight lab. We
Oh no, did I lose you or did you lose me? Oh no, it's frozen. Uh-oh, I haven't had this happen before. Are you with me, Taylor? We'll see what happens here. At least you didn't freeze on a bad face. You're looking good there. Let me see what this looks like on Facebook. I'm not sure what happened, y'all. Oh no, I lost him. Shoot. Maybe he'll come back in. One thing that Taylor and I were talking about earlier, and this is really important for us to remember as we're going in with these long COVID symptoms, an ER isn't necessarily for a diagnosis. It's more for stabilization. So we really need to be mindful of, I know we want answers. I know we do. Oh, oh, his power cut. Okay, he'll be back. Okay, he's coming back in. I know we want answers, and I know a lot of us know what test we actually need because we've been sharing these things back and forth. In what was it, a year and a half ago, 2021 summer, I started falling down the stairs. I was falling all over the place. I was completely disoriented. I was like just with it enough to beg the ER doctor, please, you need to do a brain MRI. I think I know what's going on here. I know what we've been seeing. They couldn't do that. They just could not do a brain MRI at the time. And I admit, I was pretty mad because I knew, like I knew, but they just could not do that. So I think we really need to alter our expectations of what an ER does, what their scope is. Um, they're more for stabilize it. Like we need to make sure that you are medically stable. That's one of the big roles of the ER. It's not necessarily for diagnosis. It's just to make sure that you aren't having a stroke, you aren't having a heart attack, that you are stable and ready. And again, it's something that a specialist would have to step in and take charge of that. I've actually been doing. I actually started seeing an endocrinologist 2 weeks ago, and there are a lot of tests that I've really needed for a while. So, but that's not something we can really do in the ER. So I think that's one of the big disconnects that we have right now, and I know it is really, really frustrating. Um, so we'll wait another minute here. Yeah, he's coming back in now. Okay. So I'm actually, yeah, we'll just keep this rolling. And I understand, like, I know how frustrating it is, and it's not that there are some, you will still run into doctors who don't know what long COVID is, which at this point is like, really, you live in a cave? Um, the last time I went into the ER, I told the triage nurse when I was checking in, I'm a COVID long hauler, and she's like, "What's that?" And what? And I was like, "You haven't heard of long COVID?" She's like, "Oh, that." It just kind of struck me like, "How have you been through this? And you don't know what that is?" We are at a point now where they do know what it is. Like they have heard of it. They don't necessarily have answers, but an ER is not a place where you're going to find those answers necessarily. It's a place where you can go if there is an urgent situation. Like, if you think you're having a heart attack, And then we had a heart attack town hall with Taylor and Dr. Natalia back in September. And I know we all have those symptoms, and it's like, do I have to go in every single time? No one is going to make you, well, they should not. No one should make you feel like like you're any, like you're an idiot for going in. No, no. If you have questions, if you're concerned, just go in. Because it's far easier to regret going in than it is to regret not going in. There's that I've told my doctor many times, I'm not going back in there unless I've severed a limb or I've coded, but I still go back in anyhow because it's important. We want to keep you here. We want to make sure you're stable, and because we don't always know what's going on with long COVID, it's just better to play it safe. So let's see if he comes back in pretty soon here. And I'm not going to keep him too much longer. He's got a busy practice, or he's busy back in California. So, but that's really sort of one of the big takeaways that I wanted everyone to have with this, is to know that we're the first to go through this jungle with the machete, finding our way, finding a path through this. But every time we go in, it makes it easier for the person behind us, and then the person behind them. It's not fun. It's not easy. I get that. And I understand fully that the research that's going on, everything that we're trying to discover right now, it might not ever benefit us. And that's a hard thing to deal with. It really is. But, and it's okay to just like, I understand if you have gotten to a point where you're like, I'm done. I'm just done with this. That's okay. It's okay to tap out. But we still need people going in and pursuing these answers in any way we can. And I know medical debt it's really stacking up for a lot of you. It's crushing. It is just crushing. But I something that I've told many of you is there's no price tag on your life. There really is not. Um, if you run up huge medical bills, I would rather have you here, and we'll figure out a way to deal with that than than to not be able, we've lost people that way, and it was kind of horrific. It was pretty traumatizing to think that there's a price on anyone's life. There's not. You are worth going in. So I want you to take care of yourselves, okay? um let's see. Oh man, his power like really went out. They're having crazy weather out in California right now. There we go. But yeah, and we do, I've been in situations. I've taken there I've taken some of you to the ER myself, and there have been situations where it was mishandled. The person I was with at the time, they were incapacitated. They couldn't speak for themselves. They couldn't walk, couldn't talk. And I knew this person's medication allergies, and I told them first thing when we went in, do not give her this, or this. And when they handed me her papers afterward, I went over them myself, and I noticed that they actually gave her one thing they weren't supposed to. And I looked at the allergy, and I know it's an anaphylactic reaction that she has to that. They had it listed as anxiety. I I legit got mad. They were already discharging us. So I was like, what are you gonna do? Kick me out? You're already doing that. Don't kill my friend. Um, so that's another thing to really pay attention to. If you've got access to like my chart or something on your phone, yeah, look over your records as they're coming back in. You'll be able to, that's what I do when I go in. I'll sit there and look at my labs as they come back. Oh, hey, that's weird. So there you are. I just told
Oh
knock.
goodness.
No, it's okay. Yeah, I just told knock knock jokes. I'm kidding. I did not.
I am so sorry.
Oh no, no worries.
Okay, I'm back. That was
Yay.
everything went off, and then
Oh
everything
shoot.
went back on after a few minutes, so
Well,
we're good.
you didn't freeze in a funny face though, so that's good.
Okay.
Yeah, you legit look good.
Okay, all right. I don't know where cut out on me at that point, but I was just trying to explain that, in the emergency department, we really want to do the best that we can for all of our patients. But that is what we can do within our scope and within the abilities of the emergency department, the hospital that we're in, et cetera. And we're specialists in acute resuscitation. We can do emergencies really, really well. We're the people that you want when you are having an emergency. I am not the person that you want in terms of diagnosing or managing chronic medical conditions. That's the hard part, is that a lot of the things that we end up seeing are the result of under treatment or inadequate evaluation of chronic problems or chronic medical conditions because the system is broken. And so the one thing that it's not really an ask, but I would just say is that the system that harms our patients also harms us. Like it does me an equal disservice to be unable to help when I am needed. I didn't sign up for this job to be unable to provide care to patients, right?
You have to want to do this.
Right. Like
Especially right
I'm
now.
not in this to try and, be a gatekeeper. Although we are often accused of that. But the problem is that we are at the crux of medicine and society. And so we are often seen as the gatekeepers, and you're not letting me in. And it's not that we're trying to keep people out. It's that the system does not exist in such a way that we are able to get patients to the place that they need to access care. And I can't just admit everyone to the hospital to do a chronic medical condition workup for a chronic medical problem that can and should be evaluated in an outpatient setting.
Yeah, do you
But
really want that
then,
bill?
right. And
Yeah.
we're already overwhelmed. Like we have a lot of patients already filling the hospital with true acute medical needs. So if we were to fill it with everybody who needs care, it would be everybody, right? Like everyone needs care. Healthcare is a necessity of life. That's one of the things I say when people want to argue about, is it a right? Is it a privilege? It's just a necessity.
Yeah.
It doesn't matter which side you want to argue on. Everybody needs care. And some people's care is more complex than others. And I am limited by my knowledge base and my scope of my abilities in my practice to provide the care that many patients need when they come to the emergency department. It's not because I'm trying to gatekeep those things. It's because it's literally not within my job or my ability to do those things. It's like I've had patients come in and say that they need XYZ test that isn't I wouldn't even know how to order that. That's not what I do. And it's also not a thing that needs to be done right now in the emergency department in the hospital. It's something that you need to talk to the person who's doing that evaluation about how to do that, how to access that care. What I don't want to know what that test means.
Yeah.
And I'm not going to get it back, right? So it's not that I'm trying to harm you or trying to be unhelpful. I want to be helpful as best as I can, but I'm limited in that ability. It's not because I'm limited because I don't want to. It's because that's not how medicine is set up. I'm not a neurologist or a rheumatologist or immunologist. I'm not any of those things. I'm an emergency medicine physician who is trained in emergency medicine to provide acute intermittent care. And that is not always easy to be in that position when you exist in a system that is fundamentally broken. Yeah. And so part of the reason that we are, we talk about physician burnout, and emergency medicine is one of the highest fields.
Yeah.
And during COVID, during the pandemic, the public health emergency, we have seen that rate increase in burnout to now be a majority of the people who are left.
Right.
It's now a
Who are doing
majority.
everything now, yeah.
Right. You would have thought that maybe there was like some selection bias because they were asking the people who are already burned out and left. No, they're asking of the people who are still practicing emergency medicine. How many of you are burned out and are considering leaving medicine? That is 53% in the last survey that I saw. That's incredibly high. It was down in the 20s pre-COVID. So it's gone up a little bit less than 30%. That's a lot. And the reason for that is because the system is now harming us even more than it used to. It always was harming us, but it has now reached this tipping point of being sort of exponentially broken. And it'll be interesting to see what we do as a society in addressing this going forward, because we are at a point where if we don't address this correctly, that 53%, if they do leave, it is going to be a catastrophic crisis, right? So we need to figure out how to address this. And so understand that, like, we are also human. We are trying our best, and the system that is harming our patients is also harming us, because the reason we are burned out, it's not burnout. I keep making this argument. It is a systems-based trauma. It is the fact that we cannot provide the care that is needed. We are seeing terrible things happen, and then we are facing a society that is denying the fact that those harmful things even exist, let alone are things that harm us.
Oh my God, yeah. You and I could go on about that all day long.
Right. So this is like, we are all facing trauma from the system, and I am not your enemy, right? I want the best things for you as a patient. And I think because of the power dynamic that is at play, that is often perceived as an enemy, right? You're the person that I need to convince to treat me well. I mean, I can't speak for everyone, obviously, right? But like, I don't need to be convinced to treat you well. I want to treat you well. I want to address your needs, but sometimes those needs aren't within my ability to address. And that part is really, really hard. And that's hard to explain sometimes, that like what we can do within the emergency department won't necessarily provide you the care that you need at that point, or that you deserve.
Yeah, it's not a place to seek a diagnosis. It's
right. In fact, I forget exactly what the study said, but it was something to the effect of the majority of patients who walk out of an emergency department do not receive a diagnosis. And that's not a failure of emergency medicine.
Yeah, you're stable.
Like, if you walk out, that means hopefully we have done our job correctly, and we have ruled out any emergency problems and addressed what we could to the best of our ability. And if that is about pain or some other form of suffering, hopefully we have done something to be able to alleviate that. But at a bare minimum, our job is to make sure that you are like literally our legal responsibility by EMTALA for every patient who shows up into the emergency department. So EMTALA is the Emergency Medicine and Active Labor Treatment Act. So if you have a true emergency medical condition threatening life or limb, or you are in active labor, we are required to treat you by law, whether or not despite your ability to pay, or regardless of, I should say. That is by law what we are required to do. And so that can mean something as simple as a medical screening exam where I determine that you do not have a true medical emergency that requires treatment. Obviously, we are going to try to do more than that. But that is the bare minimum. Is I have to, and so that's what we try and do, in some places, like if you were, well, and here's something worth explaining. If you're brought in by ambulance, it doesn't mean I'm going to see and treat you right away when you get there. If you don't have an emergency medical condition, you won't necessarily go straight back to a room. You might go from the ambulance, you can walk walk to the lobby and wait in the waiting room with everybody else. But what we often do is we'll see patients as they come in by ambulance and say, you don't have a true medical emergency where you need to go straight back to a resuscitation room. Then you go wait in the lobby because we are full, right? So you're not jumping the line. We are doing our legal response, fulfilling our legal obligation of performing a medical screening exam for an emergency, and then determining the appropriate location for you to wait for your care. That is part of triage, right? So coming in by ambulance, you still face triage. The difference is that you will face triage in the ambulance bay and not in the waiting room. But you're still triaged, right? And so that is evaluating for that medical emergency or being in active labor.
And something I was talking about while you were coming back on. If you're in doubt, it's far easier to regret going in than it is to regret not going in.
I say that all the time,
So
and I
right time in
can't.
your life.
Yeah, I can't tell you the number of times or the amount of time I spend apologizing to patients who say, "Oh man, I really wish I didn't come," or I'm sorry for wasting your time, or
Yeah.
it's like, no,
Oh, you deserve
that like I consider that a win for doing my job. If like
Yeah.
you're like, "Oh, I wasn't having a heart attack,"
Thank
like,
goodness.
okay, good. Like, I'm not expecting you to know if you're having a heart attack. In fact, I'm
Right.
not expecting me to know if you're
Just
having
come
a
in
heart
with your
attack.
leads already on and
Like, that's why we do tests. That's why we do
yeah.
EKGs. That's why we send troponins. Like, I can't tell you with my like superior knowledge and X-ray vision that like for sure what's going on just based on you telling me. Like, I have chest pain that's radiating down my left arm. Yeah, high concern for a heart attack,
Yeah.
right?
Well, if I'm on the floor, take me in.
Am, am I sure that you're having a heart attack? No. That's why we do tests. That's why if that is happening to you, you should be in the emergency department where we can do the appropriate tests and evaluate you. And if it's not a heart attack, then that's a good thing. That's not wasting my time.
Yeah.
That's literally my job.
Yeah.
And if you are having a heart attack, then I will be sure that we get you to the appropriate place. And if I am in a large enough institution that we have cardiologists or a cath lab or whatever, then you will go to there. And if we are not, then I will send you to a facility that does, right? That is part of my job. Ruling out emergency medicine problems is my job. And so if you come in with concern for an emergency medical condition, we will certainly evaluate and treat that thing or reassure you that it is not that thing. But that doesn't mean that we will know 100% what that thing is.
Exactly.
Right.
And I think
So,
that's the frustration for us. We don't know what any of this is.
right. And I share in that because I don't know.
Exactly.
And I would love to know. I wish I was
Yeah.
smart enough. I had already done all the right tests to know.
Yeah.
The reality is that like a lot of the things are beyond our scope or our abilities, or we don't understand them enough yet as a medical community.
Exactly.
But some of the right tests to do can't be done in an emergency department. You need to, and a lot of them are done in outpatient settings, right? Like, one of the things that I try to explain sometimes to people is like, they're like, "Oh, well, I need X study." And it's like, even if I admitted you to the hospital, they don't do those here.
Yeah.
Like, those are done in the clinic. You just have, and I get that it's frustrating and you have to wait for your appointment and all of those things. Like, there are literally things that we don't even in the hospital have the ability to do because they are not hospital-based assessments.
Yeah. I worked in
And
nuclear medicine for a couple of years too.
right,
I love that. That was
right.
fun.
A lot of these things are done through those subspecialty clinics, literally not in the hospital, because the hospital is also for treating acute needs generally. I mean, they can be exacerbations of chronic needs, but the goal is to fix the problem to get you to the point where you can then go to complete an outpatient assessment. And sometimes that includes those specialized studies that don't necessarily need to be done in the hospital.
Yeah,
So
get stabilized. It's not
yeah.
diagnosis, stabilize.
And I've literally had times where I've called specialists and been like, "Hey, I really think this person needs this test," right? And like, "Oh yeah," like, I have to see them in clinic. So, oh, okay. I'll send them to you. And, hopefully that if I express that like this person is in a more acute need, maybe that will make them see an urgency. But honestly, a lot of the things end up in such a circumstance, like they can't make it any faster, right? You can't double book every patient slot all
Can't
day.
just do like 2 gallbladder surgeries at the same time.
Right, right. There are only so many of us, and we can't necessarily work any faster. And I think that's one of the other important points is like, even in the outpatient setting, people are frustrated by the fact that physician time is so limited, that you only have like 15-minute appointments. But patients also want to have access to care. And so we can't spend an hour with every patient as much as we would like to, because that will help us get to where we need to be in the shared understanding about your medical needs and your treatment, because we need to be able to provide care to other people, right? They're just
an increasing number of people too coming in with the fallout
right.
of COVID.
If we want to be able to provide that level of care, we need so many more of us, and we need to improve the way that those longer appointments are reimbursed, because clinics have to be able to keep the lights on and pay everybody that's necessary for the clinic to operate, right? I think people underestimate the amount of administration that is needed simply to get paid.
Yeah.
Simply to
It's a
bill
nightmare.
insurance companies, to argue with them because they don't want to pay. It's not just paying a physician's salary, right? Like like I said, the amount that a physician can bill is based on physician codes, and the hospital system, the facility fees account for a lot of it. But out of that physician reimbursement, we're paying for all the administrative stuff as well. So the amount that is actually seen by the physician becomes increasingly small, right? Because we have to have all that administrative work, which requires a lot of people, which requires a lot of salaries. And so what happens at the end of the day is like, you got to pay for the clinic, you got to pay to keep the lights on, you got to pay for all the people who work there just to get paid. And then you have to make a living. So if we're not going to reimburse better and we don't have more of us, we're not going to be able to change the amount of time that you can spend with a person. Because as compassionate and empathic as they might be, that's also what makes them want to see more patients so that they have access to care, and that limits the amount of time that you can spend with them, right? It's a vicious cycle. We can only do so much. And that's why it takes a long time to get into clinic, and then you're frustrated because it's only a 15-minute visit, and then that physician is burned out because they only get to spend 15 minutes with a patient at a time, and they don't want that either, right? It's the system.
My PCP starts at 7 in the morning and he goes until like 7 at night, 4 days a week. Dude, how are you doing this?
I spend half my time in the emergency department and half of my time in an addiction medicine clinic. And
which, by the way, thank you. I did that in college. I did a lot of things.
I love it. It helps me manage my stress and frustration with the hospital-based care, and my limitations in the emergency department. For example, not being able to address underlying problems like substance use disorders.
You get a lot of that.
Yeah, we get a lot of that in the emergency department. It's just so frustrating not being able to do better for our patients, right? So, but I am often double booked all day. And fortunately, a lot of my appointments are telehealth, and that can be fairly quick. And it doesn't require people to come in, and they're not, sitting in the waiting room and all that. Right. All of which is great, and it's good for patients, and it's good for me to be able to keep up when that happens, because some days you just get busy and you end up seeing 30 some odd patients,
Oh God.
like I did yesterday.
Oh God.
And yeah. And right. And so it's like, I was just like emotionally exhausted by the end of the day because I was like constantly being like, oh God, I'm behind. It just never ending, right? Like if you're double booked, you're like, oh man, I have 2 patients in this 15-minute window. Like, as much as I love talking to patients, hopefully one of them doesn't really want to talk to me because I gotta catch up, right?
Yeah.
So sometimes that happens, and it's okay. Not everybody has to want to talk to me.
I used to shoot
Sometimes,
rubber bands at the nuclear medicine doc
yeah,
I worked
yeah,
for. Hey, do your dictation, dude. It was a
right.
crack shot.
Yeah, and then charting, like we haven't even talked
Oh
about that,
God,
but
yeah.
trying to keep up with all of that while you're just running, right? You're hustling. So it is really hard, and know that we are trying. We want to provide the best care that we can. We are running in the emergency department, often literally.
Literally.
Um, and we do care, and we are there because, and we are running because we care, and we want to be able to provide care to all the patients all the time. That's just hard.
If you didn't
Um,
care, you would not be there.
no, if you didn't love it,
Yeah.
you would have left by now. Yeah, it's,
Right.
it's it's hard there. I love it. I truly love all of my job, both aspects of my world now. I do, and I do it because I love it, but man, it's frustrating sometimes. And I get it, right? Like I have the choice to do that. I choose to do it because I love it. Not all of our patients have a choice to have the conditions that they have.
Yeah.
And to exist in a system that's broken. I exist in a system that's broken, not necessarily by choice, because I live here and I don't live anywhere else, and I'm not a citizen anywhere else.
Yet.
Yeah, yet. But I exist in a system that's broken, but I have a choice to continue to do my job. And our patients don't always have that choice. And so I do empathize, and I understand that it's frustrating. I just I want people to understand that we really do want to do the best that we can, and part of that is, I mean, as you were talking about, expectation setting. We have to set the right, appropriate expectations, and sometimes that bar is frankly, unfortunately, going to be too low for what we want and what we need and what we deserve. But that's the reality of the system we are in, and I know that's hard.
It sucks, but and the other thing, like, it don't put a price tag on your life. If you are concerned about a bill, please know we can figure that out later. Please go with it.
Yes, and know that there are always ways to fight
Yep.
In medical billing, and hospitals. Look, hospital systems make a lot of money, and they are partly able to manage the amount that they make by writing things off as charity care. They're not doing it for nothing. They get tax breaks from this, right? They can say, we provided $1 billion of charity care this year
One of the things
based on made up numbers.
Yeah, well, I also used to go through old claims like 30, 60, 90 days, and I would sit there and call insurance companies all day.
Mhm.
Hey, why haven't you paid this? What's going
Yeah.
on here? It was my job to argue that
Oh
it has to be
man.
paid.
Yes, the
I'm a
insure we could
bulldog with
talk
that.
we
Oh
could
my
talk
God.
all day about this, and the insurance companies just right, as we were talking about, the amount of administration that is necessary just to make insurance companies do
Yeah.
their jobs and
And,
pay for your care
and they
is
have,
just
and
so
they
frustrating.
have enough of that now. You can't. You don't have the staff for it.
Right. And so then it gets behind, and then they're not paying for your care, and then
Oh,
you
they
get a
do.
bill from, and you're like, why am I getting a bill?
And they paid
The
you
No
14 bucks,
Surprises
but you owe
Act.
1400.
Yeah. The No Surprises Act should be hopefully addressing that and bringing insurers to the table to sort this out. We will see how that goes. It's only more recently the details are being sorted out. I have heard of some physician groups finally actually getting paid by insurance companies. So it's what the No Surprises Act did is, instead of these what we call balance bills, where like the hospital's like, your insurance company is not paying for this, or the physician group, your insurance company is not paying for this, then you're stuck in the middle. We're going to bill you. Somebody needs to pay for the care that you received, right? And like, I don't think anybody's arguing that care should be free, should just be paid for by the, insurance company that you paid to insure them,
Yeah.
insure your care. But so those are called balance bills, or referred to as surprise bills, by the insurance company PR firms.
Uh,
But
yeah, the nice thing when I was doing this, my dad was the hospital administrator. Only one
right,
time did I have to play my ace of spades and be like, okay,
right,
I've been putting up with you for a year. He knows, insurance commissioner
yeah,
knows, and
yeah,
y'all are out.
yeah. But there's a dispute resolution process where the insurers have to come to the table with either the hospital or the physician group in terms of paying them back
Yeah.
or reimbursing them for their care. And they may say, oh, well, we don't want to pay that much. We think that's unfair. So
Well,
both sides come to the table with a number that they think is the appropriate or fair amount. And it may be less than the bill. It could be $0 from the insurance side. We don't want to pay you anything. And then an independent arbitrator decides that's the fair number, and that's what gets paid. And that could be the hospital or physician group side, or that could be the insurance side. But it's just, this is what the closest approximation of the most fair amount is. And so you insurance company pay X physician group for the care that they've asked you to pay for. And then the insurance company has to pay for that plus the cost of going to arbitration for the physician group. So that's what the No Surprises Act did. Hopefully that does bring everybody to the table a little bit better, so they play nicer in the sandbox and insurance companies are paying their share. But yes, you can also go directly to the hospital and ask about charity care.
Yeah.
They can help you. And they often will work with you, even if it's to bring the overall cost down, even if it's a payment plan. Like, there are a bunch of ways to address this. So yes, coming to access care is, I would rather have you come and feel like you didn't need to be there than have you need to be there and then not access care.
Yeah. Yeah, and I've worked in plenty of offices where, hey, you want to pay $10, $20 a month, and you've been doing that for months. A lot of times they'll just write it off at the end of the year. So,
Yeah, exactly.
but there are options. You are worth it. So please go press start.
Absolutely.
Well, I don't want to take up too
Absolutely.
much of your time because I know you are a hopping dude. Thank you so much for coming
Thank,
in.
thank you. Thanks for having me on. And
Oh,
thanks for addressing this topic. I think it's incredibly important.
it is. It really is. It's a big source of frustration for everyone. It's this really rough interface, but
Yeah.
but
It's a tough conversation, but I'm glad that people like you are having it and trying to sort of hold that space for this conversation. So thank you.
oh, gladly, yeah. Well, I'm gonna go ahead and sign off here. It's been great having you, Taylor.
Thank you so much.